Well, here's one of the ways that I approach patients. These are different levels of disability and function. And my job, my major job as a geriatrician, I think, is to listen and think. Listen, 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 and find out what's wrong, and then think, how can I really make this person better? And the way I think through that is, number one, can I do something that's effective? Do I have a treatment, a surgery, a counseling skill, a drug that will help this person, relieve pain, whatever? Number two is, what is the side effect of what I'm doing? How risky is it? The third thing is cost. I think we have to be sensitive to that. What is the cost effectiveness? And fourthly, is sort of the overall goal of geriatrics. What is going on with this patient? What is the big picture? What is this person's preferences, their social support, their comorbidities, their medications? What can I do for this person? What's realistic? And then educate the family and the patient and make some choices and follow up. And so that's how I'm looking at this big picture. What's effective, the side effects, the cost, and sort of my gestalt on where they are. And then what I try to do is put people like in a category of vigorous, sort of average, and frail, and then tailor my approach to that. That's what I like about geriatrics. It's kind of thinking through these sometimes almost impossible problems, unsolvable problems. I like geriatrics for two main reasons. One is that there's a lot of science in geriatrics that is not practiced well. So we need to bring the evidence of what's out there into practice. But the other thing is there's a whole lot of art. And there's a lot of patients that are way beyond the edges of science. And I think that's where we have to look at the whole big picture and say, I know we've got this evidence, but you're different, your background, how can we help you? And I like combining that science with the art. It's the final frontier of medicine. You know, we're never going to solve this issue of how to take care of 90 and 100-year-olds. So I just find it's a constant challenge. Each person is so different, and I enjoy that part.
Thank you, Doc.
Sit. Miss Linda, you want to sit there?
Medication compliance is a big issue with older adults, mostly because they may not have a caregiver and they forget to take the medication. But that's not the case with Mr. Hutch.
He's in his 70s. He has mild dementia. He's also blind, both from diabetic eye disease and a lye accident to his eye several years ago. He has a young wife, I think a generation younger than he is. And he has some minor medical problems. He has diabetes and hypertension that are fairly easy to control. Now, your wife tells me that you don't like these pills I gave you too much.
No, they kind of mess with me, Doctor.
Tell me about that.
You know, I don't know. It's just I see bad things. And
You see bad things?
yeah, and I don't see nothing good. One time, it was an elephant had got in the house, and I'm doing all this in.
Do you understand what he's talking about?
At night he do.
At night.
He hallucinates some?
Yes.
Yeah.
Do you realize the elephant is not there? Does it seem real to you?
Well, no, it didn't. After I had, did Tarzan thing. You remember Tarzan? Yes, Tarzan.
Get him to do his judo.
But he takes the metformin with no trouble.
No
So
problem.
that one he'll take. But we can't get him to take his blood pressure medicine or the
We
aspirin.
don't, no, he won't, and he only want.
The metformin.
Right, he
You're
should
supposed to
take
take it twice a day, but what you can get him to take is one metformin.
Yeah, he'll take
No,
it.
I do it on my own.
Yeah, he won't, I
That's
used to
right.
give it to him,
Okay.
but now he do it himself.
But he's not taking the aspirin, he's not taking the lisinopril, and of course he's not
Aspirin. What aspirin will you take, man?
The bear aspirin.
the baby aspirin. The biggest problem is it's not a problem, but he's not very compliant with his medicines and he's very religious.
Remember, I am a pastor. But now let me tell you something.
Yes, sir.
I know we have a Jesus, right?
Right.
All right. So, Doc, that's where I keep my trust and faith in Jesus, and that's when things don't happen to me.
How about your doctor works along with Jesus?
All right. That's
How about
right.
the
He went through it.
medicines and your faith work together?
Well, see, I tell you, that's something that I never have been too good to take. Cause I never smoked a day in my life. I never drunk a drop of liquor a day in my life. Never have in my life. That's a God have no truth. And see, I always tell my mama, if you take care of your, what I do?
You can start preaching.
That's what I'm saying. That's what I'm just going to do. But see, all we have to do is take care of ourselves.
He will only take one medication, and that somehow that connects to his religion, that he'll only take one pill.
Jesus went through doctors,
I agree with that.
and he also went through me.
So I've had to prioritize. of his medications, what do I think is most crucial for him, and bargain with him. Let me ask you this. I'm going to give you a shot today. You have a vitamin B12 deficiency. I'm going to give him a shot. That'll last a month or two.
Right.
Good. You're taking your diabetes pill.
Yeah.
Yes. Could I convince you to take one blood pressure pill, or maybe not?
No, doctor, I don't think I'm gonna ride them horses.
You're not going to ride that horse.
No, I'm gonna go as my father tells me, which is out in heaven.
And today I didn't confront his religion, but I suggested that why couldn't I work within his religion? That his God and religion and doctors can work together. We can have the same goal, and perhaps that we can together provide a better outcome. I enjoy taking care of them, though. He's lively, he's humorous. He's not going to do most of what I suggest to him, and that's okay. Let me tell you, I think the most important medicine he's on is his diabetic pill, the metformin.
Okay.
So at least he's chosen the drug that I think is crucial for him. He would take both of those, but he has to make his own decisions.
And how long had he been a patient with you?
I think I've known him for about 2 years. It's
Okay.
whatever you think is right for you.
Okay, well, see,
We tried dementia medications, but he just would not take them. He just thought they were silly. So it's not absolutely essential that he's going to have a stroke tomorrow or something if he doesn't take these medicines. I just want to keep you as healthy as you can be. So I decided to concentrate more on his medical issues. Older people are often fairly compliant, but in his case, his dementia, and I think, I'm not saying a delusion, it's not a delusion, he's not delusional. He has a religious belief that pills are unnecessary and doctors really you don't need a doctor, you can heal through faith. I'm not going to directly challenge that. I think that's inappropriate, but maybe I can work with that. This man's in front of me with his concerns, his background. I have to take him as he is. How can I help him? So today, for example, he said he was only going to take one shot, but his wife convinced him to take two.
okay, well, see, I would like to go by the doctor rule also,
Well, why don't we do
too.
this then? He got the B12 shot, and his wife said give him the pneumonia vaccine. So we used the caregiver there to help us get that shot in him. You decide if that'll work for you. It may work, it may not. And I think we'll just see how he does.
When there are compliance issue with your patients, what kinds of strategies do you use to help them to be more compliant?
Well, we need several people helping with that. So can I get your daughter or your wife to assist you with that? We can get a box that medications are put in. Some patients are still living by themselves. We can see if a family member can drop by once a day or once every other day and see if those little boxes are empty. We can try to simplify the drug regimen, try to get everything down to 1 dose per day of medicines. We can also try to reduce the number of medications where possible. Or we now have combination pills where we can treat more than one thing put 2 drugs in 1 pill. So those are all some strategies. Also ask, are all these drugs truly necessary? What is the goal of care for this person? Especially as they get frailer. As their dementia worsens, as their organ failure worsens, do they really need tight control of diabetes? Is prevention of stroke and heart attack in this particular patient still a goal? Should we put them on a powerful blood thinner? What is the risk-benefit ratio? And those things change over time. And I find that many patients are just taking too much medication. And we can simplify their regimen and they'll perk up, their function will improve, and we go from there. There's not a lot of randomized trials in 85-year-old frail people on 8 drugs. In fact, there are none. Any breathing trouble? You're eating good?
Oh, yes, man, that lady over there, ooh,
She can
child,
cook.
said nothing. Man, you know what you should do? You should eat 2 of that lady biscuit. You just melt in your mouth.
You can bring me a plate of them next time.
Oh, no.
No nausea or stomach problems. Sometimes metformin causes stomach trouble. None of that.
Yeah, so far, no problem.
What level of severity do you think
He's still mild. And the way I would gauge dementia is based on their function. And so a mildly demented person is either independent in their activities of daily living or needs minimal assistance. A severely demented person is dependent on all other ADLs or most of them, and moderate's in the middle. A mildly demented person can live by themselves. A family member can check in on them. Now, he does have blindness, which complicates things because he needs some help with that. A moderately demented person can be left alone briefly. You could go out for an hour. A severely demented person needs constant attention. So it helps me focus where they are and then focus resources for that person. Is their living situation appropriate? So where he is, with his wife, she doesn't have to be there all the time. It's perfectly safe. Just take a listen to that old heart there. See how it's doing.
Okay.
Would you treat him differently if his dementia is more moderate than mild?
Well, the major thing is you can decide whether to use medications. You know, we've got medications to use which are very minimally effective. I think we can offer that. But there's a lot else to do for people who are demented. First of all, we need to make sure that we've got their comorbidities well managed. Are they properly diagnosed? Have we taken them off of medications that are anticholinergic, that are sedating, that increase the risk of falls? Have we looked at nutrition? Are we giving them meaningful activity? What's an appropriate activity level for a person, for example, as they become demented? We can give suggestions for that. There's often caregiver stress. Taking care of demented people is usually not too stressful on the demented person. But the caregiver is very stressed out because the person just gets sicker and sicker and sicker no matter how much effort they put into it. So finding a way to get that person some help through support groups or services is useful. And then, of course, toward the end of dementia, the person's going to need either round-the-clock care in a home or probably nursing home care. It's just overwhelming for a family to do that. So that's part of our effort there, is to look at the whole picture and mobilize resources when the person needs it. Your wife is right. It protects your kidneys, it protects your heart, and it protects your brain from having a stroke.
He'll take both of them. Yeah.
He will.
Yeah.
I can go ahead and get the nurse to do that?
Yeah.
Missing a dose of metformin is okay, but taking lisinopril like 2 days and skipping 2 days and going out, that's risky. So he either needs to take it, and if you can't get him to take it regular, then don't do it.
What is called for stroke or something?
Yeah, I don't want you to have one.
No, and I'm not.
Good.
I'm not gonna have a stroke.
You're going to will it away?
Well, as long as my health don't fall.
There you go.
That's what I put. in my
So
life.
how about we treat your blood pressure and we rely on the Lord all together? My idea is to keep the person in the least restrictive environment, even if there's some risk to it. You know, for most people, they'll accept that risk. Don't prematurely place people in nursing homes. If we need that level of care, that's fine. But there's often other options.
All right.
It's a pleasure to see you.
Same here. May God bless.
Yes, God bless you, and thank you for coming by today.
Thank you, kind.
You had any other questions about him?
No, that's about
Nurse
it.
will be in just a minute.
Okay.
Yes, Doc. If I ain't sick, I'm still gonna come by and see you.
Well, your labs look good. I'm pleased.
Great.
Um,
Thank you for seeing me.
So tell me what's gone on since you had surgery on July 23rd. The third patient I've known for 3 or 4 years. She's actually the grandmother of one of our nurses. Your pain was very intense before the surgery.
Right.
So is the pain better?
Oh, yes, sir.
So the pain's gotten better. So you had your surgery, and I know in the hospital you did well.
I'm not progressing forward, getting better.
Now,
I've been shut in so long.
she has a panoply of problems. Most recently, she's had pneumonia and she had a stroke while in the hospital. It's actually a good place to have a stroke, so it was promptly evaluated and treated. And she also has crippling arthritis of her right hip. It was agonizing pain. We tried lots of pharmacologic treatments, including opiates. Orthopedic surgeon did some injections, nothing helped. So she really needed a joint replacement. But here's the problem, she just had a stroke. So that makes her risk of surgery quite excessive. Generally, we wait 6 to 12 months after a stroke to clear someone to have an elective orthopedic operation. When I saw her about 6 weeks ago, I talked to her and her family, and she was miserable. And I told her, here's the dilemma we're in. Do we take this risk right now and try to do your surgery now, or do we wait? She opted, and her children fully supported doing early surgery. And so I didn't convince, but I cleared her for surgery, knowing that she's at increased risk. And she did fine through surgery. She's done real well. Except now, I think her problem is she's become fearful of falling. She went through rehab well, but her sons, who are two wonderful boys, that somebody is with her all the time, she's never alone, say that since she's been coming home, she's lost motivation, and she just complains she's weak all the time. Well, weakness as a symptom in an 80-something-year-old person could mean a lot of things. So I need to do a very thorough medical evaluation. That all looked fine today, and I think her problem is she's got some depression, which she's had for a while, which is now preventing her from rehabbing further. I thought you might be having some substantial bleeding, but her hemoglobin's 11.3, which is fine. It's not normal. Normal would be like 12. But she's not having any substantial blood loss. Her stool test is positive, but that test can be positive from the iron she takes. So I've motivated her children to keep pushing with the therapists. I've increased her antidepressant, And another option would be to get her some counseling and therapy. We have not done that yet, but that would be another option which I may reserve if what we did today doesn't help. Her granddaughter is a nurse, a very skillful nurse, so I communicate by email to her and keep in touch with her in between visits and make suggestions as we go along. I'm going to take a listen. She didn't have a devastating stroke. It was a minor stroke. And I said, you know, your risk is higher now. We have to just look at the pros and cons. What is the quality of your life now? Can you sit up just a little bit?
Yes.
Let me pull this up. She was in terrible agony despite being on strong opiates. Deep breath. She said, I just can't live this way. It's miserable. So total hip replacement has about an 85% rate of completely relieving pain or markedly relieving it. That's not 100%. And she has had total relief of her pain. So she is glad she had the surgery. So I don't think that was a bad decision. And she accepted a small increase in risk of heart attack and stroke, which didn't happen, thank God. And now she's kind of stumbling again in her rehab, and I think we need to, you know, do a comprehensive look. Why is this happening? And try to move her along, keep her mobile and keep her getting better. She wants to be more functional. She sees herself declining physically, and it's very distressing to her.
What's your prognosis for her?
I think my prognosis for her is still pretty good. I'd say fair to good. It's not excellent. She has a lot of comorbidities. She's still cognitively very strong. She's not demented at all. She has a wonderful support structure. Her 2 sons and her granddaughter are just dedicated to her. If there's a way for her to get better, she's going to. They manage her medications meticulously. They make sure she's moving and she's eating well. So I think, you know, that's very powerful. The best predictor of improvement is function and support. It's really not their blood pressure or their FEV1 or their hemoglobin. It's what resources this person can bear. And I think she still wants to get better. Some patients, you know, really don't want to get better. They kind of give up, and that's hard. But she's not at that stage. Also, your chemistries are okay, your kidney function, your potassium is okay. I think what we might want to do is boost you a bit on this Remeron tablet,
Okay.
which is the medicine for your nerves.
Yes.
You told me this is 7.5, but you gave her 15 milligrams today?
No, sir, she was at 7.5 at the
Yeah.
rehab. We had dropped back to a half of that.
Half of 7.5.
Before she had the surgery, we was giving her, you prescribed a whole one for her.
Yeah.
She took it
7.5.
7.5. She took it for about a week,
It may
and
be
then
big.
she got kind of dizzy and things. So
All
we
right.
cut.
I don't want to go up to 15, then I want to go up to the 7.5.
Go to-
Half of 7.5 is probably too low to do anything. So let's go
Okay.
back to the full 7.5 milligrams,
Okay.
and let's see how that does.
Okay.
Is she getting any therapy at the home?
Yes,
Yes.
they were supposed to start today.
But I think medically you're okay.
Well,
Your
good.
lab tests and physical exam look okay, but I think let's see if we can boost up her Remeron. So,
Well, depression is devastating because they don't have the motivation to go forward. How do you deal with depression on top of all the other comorbidities?
but treatment of depression can be remarkably effective. And I would actually rather someone have depression as a cause of weight loss and fatigue than cancer or something bad that I can't really treat. Depression is treatable. So if I see depression, I don't know, I like the diagnosis, I don't want them to be depressed, but I feel like this is something we can treat. At least I have a chance at getting this person better on. I would like to just see how you do. I think physically it's okay for you to continue with your therapy. And I think if we get you on the higher dose of the Remeron, you may get some of your energy back.
Thank you.
But let me tell you this, the good news,
Yes.
you came through a major orthopedic operation without any medical complications.
Well, that's great.
Remember, that was kind of risky because you had a stroke recently.
Right.
But you did that real well.
Yes.
And now we want you to continue to rehab and get back on your feet.
Yes.
The pain is better, isn't that good?
Oh, yes, sir. The pain's much better.
So what that tells us is that this is a good thing to do. But I would like you to keep working with your therapy,
All right.
and I think it's medically safe for you to do so. And I think if we can give you the higher dose of the Remeron, you'll do better.
Think maybe that'll increase my appetite some too.
Yes, that's one of the side effects of Remeron.
That's what I was thinking.
Did you know that? My major job as a geriatrician, I think, is to listen and think. Listen, 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 and find out what's wrong, and then think, how can I really make this person better? And the way I think through that is, number one, can I do something that's effective? Do I have a treatment, a surgery, a counseling skill, a drug that will help this person, relieve pain, whatever? Number two is, what is the side effect of what I'm doing? How risky is it? The third thing is cost. I think we have to be sensitive to that. What is the cost effectiveness? And fourthly, is sort of the overall goal of geriatrics. What is going on with this patient? What is the big picture? What is this person's preferences, their social support, their comorbidities, their medications, their function? What is realistic? And so that's how I'm looking at this big picture. What's effective, the side effects, the cost, and sort of my gestalt on where they are. And then what I try to do is put people like in a category of vigorous, sort of average, and frail, and then tailor my approach to that. You got people looking after you.
Yes, they keep my medicine dosed out.
And so I think that's kind of the skill of geriatrics, is integrative. Look at this big picture. What can I truly do for this person right in front of me who's not entered in any kind of clinical trial, wouldn't even be allowed in those trials? What can I do for this person? What's realistic? And then educate the family and the patient and make some choices and follow up. That's what I like about geriatrics. It's kind of thinking through these sometimes almost impossible problems, unsolvable problems. It's a pleasure seeing you.
Thank you.
I want you to get better, okay?
Thank you. Thank
And
you
I think-
for everything.
I think you will. Just keep working, okay?
Yes, I'm trying.
Good to see you guys. Yep.
Appreciate it. Thanks, sir.
Bye-bye. Well, here's one of the ways that I approach patients. These are different levels of disability and function. And my job, my major job as a geriatrician, I think, is to listen and think. Listen, 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 and find out what's wrong, and then think, how can I really make this person better? And the way I think through that is, number one, can I do something that's effective? Do I have a treatment, a surgery, a counseling skill, a drug that will help this person, relieve pain, whatever? Number two is, what is the side effect